So hello and welcome to this ARMA webinar on services to support people to live well with pain. This webinar is part of a programme of work on pain that we've been delivering over the last year. And that work is part funded through a charitable donation from Pfizer Limited. Pfizer have had no say in the content of the programme. It's thanks to the support of sponsors that we can keep our webinars free to access. My name is Sue Brown and I'm the Chief Executive of the Arthritis and Musculoskeletal Alliance, ARMA. We bring together patient and professional groups to work for better health services for people with musculoskeletal conditions. You may know us through our resources, our virtual conference and our monthly newsletter. During the last 18 months, thousands of MSK professionals have been using the links on our website COVID page to access the latest information and guidance. If you've not already subscribed to our newsletter, it's a great way to keep up to date with our work and our members' activities and key MSK policy information, and also find out about future webinars. We're a very small charity, so if you like what we do to champion the voice of MSK, do consider becoming a supporter and making a small donation to help keep supporting change and speaking out until everyone can receive the best quality treatment and support. Details of all this is on our website, arma.uk.net. One of the common factors in MSK conditions is pain. So ARMA has had a long interest in ensuring that people who live with pain can receive the best possible support. You will find a range of publications on the subject on our website, and we will be publishing more in the coming weeks. So I am delighted today to introduce two speakers who have a wealth of practical experience in planning, designing and integrating pain services, and a wealth of insight into how to support people who are living with pain. So I'm now going to introduce our first speaker, Mohammed Shoaib, who's a pain specialist physiotherapist and clinical lead for Connect Health Pain Services and is based in West Yorkshire. Over to you, Shoaib.
Good afternoon, everyone. Thank you very much for tuning in on your Friday lunchtime while you're probably munching away on your lunch and enjoying some unseasonably warm weather. So hopefully we'll try and keep this as fun and interactive as possible while people begin to wind down on a Friday afternoon. So yeah, thank you, Sue, for inviting me for this session this afternoon. So by background, I'm a pain specialist physiotherapist and work in the West Yorkshire region, in particular in Huddersfield and North Kirklees, which makes up kind of the Kirklees CCG region now. And I will just, I'm going to be sharing my insights and thoughts and really my 2 pence worth in how we've tried to make the local community pain service more integrated into the local region and have helped to improve patients' quality of life beyond what the service can offer to help patients to fulfill their values beyond our service. So I'm just going to share my screen now. Okay. So yeah, I'm going to be talking about how we've helped to develop some better collaborative working in the region whilst I've been clinical lead for the last few years. And yeah, if there's any questions, feel free to pop them into the chat box and I'll try my best to answer them to the best of my ability. But I will share my email address at the end. So if anyone has any more kind of personal questions or kind of any private question, they're more than welcome to send them to my email address on the last slide. Okay, so the situation a few years ago, kind of well before COVID, and kind of historically really, was that the community pain service was seen as a place for referrers to send patients to receive injections or pain medication reviews pretty much in isolation. So it was kind of very much thought to be kind of a very passive intervention service in that the patient would go to their primary care referrer So this is not just GPs, but could be the advanced nurse practitioners, and now with the advent of first contact practitioner physiotherapists, it was considered to be kind of the patient would attend their primary care provider. They would report pain in a body part, usually the spinal region, and then the referrer would say, right, yep, either more medication or an injection, and then refer on to us. And that was kind of the 10-minute consultation. So there was a lack of understanding as to what exactly the community pain service in the region actually did. But then looking out from within our team to the local area, there was a limited awareness of what other services in the region were providing and how we could collaborate and how we could work with other services, partnership working, to help patients live well beyond our service. Because many patients, once they entered our service, many became dependent on the follow-up appointments for almost long-term care, because they felt we were in the luxury of offering 45-minute assessment slots and 30-minute follow-up sessions, and that is I guess a bit of a golden luxury compared to GPs or any kind of primary care referrer, where you're lucky if you have a 10-minute appointment to support a patient with long-term pain. So often patients developed a sense of dependency and almost used our service to a degree for kind of offloading some kind of if they were lonely or isolated, or there were elements of kind of historic abuse in the patient's background, and we struggled then to kind of know how to support these patients beyond our service. So that was kind of the looking out. So there was the kind of looking in, kind of how other services or the referrers really perceived us. But then once we received the patient, it was then how do we work with the patient to, I guess, being the kind of the one-stop shop for patients with pain, to kind of really maximize that biopsychosocial model. So referrer guidance. What we decided to do was within the region, there was a high turnover of primary care referrers. So again, advanced nurse practitioners, GPs, etc. So it was really hard to kind of run primary care referrer education sessions because the turnover of staff is significant across the CCG area. So we made a decision that when referrals were received and the referral just simply stated, patient has low back pain, would like a repeat injection, or would like morphine, we would send this back to the referrer and ask the referrer to initiate the conversation around that we're not commissioned just for injections or medications alone. We're commissioned to provide the kind of the pain rehabilitation, self-management approaches as well. And injections or the medication reviews form part of the overall package of care, not just the only part of care. So what we did was that shifted the focus back to the point or the point of source of referral. So the primary care referrer could begin moderating those expectations of, right, well, you might get referred to the community pain service. They could give you an injection, but there's a rehabilitation or self-management set of skills and techniques, you will need to engage with to help improve your quality of life. So it helped to moderate patients' expectations before they reached us. So kind of we went right up to the top of the stream at the point of referral. And this, like the diagram helped to show, kind of, it really helped to moderate the expectations and kind of what the clinical reality is and what the patient's expectations were. But this also helped the GPs or the advanced nurse practitioners or the primary care referrer to improve their caregiving approach and the shared decision-making process with patients, rather than simply the patient attending and the patient stating, I've got back pain or I've got neck pain. Can I have an injection or can I have stronger painkillers? And yeah, okay, I'll refer you on to the pain clinic. So it helped to really kind of nip that in the bud and really help to shift the focus on and help the patient to become better informed. Again, in some cases, that wasn't always the case, but there was definitely a better upward trend, and that really helped. The next point of accessing to the service was via the local musculoskeletal triage service provider. So when they were referring patients to us, that when they did a musculoskeletal objective assessment, where they felt patients would benefit from a specific targeted injection, again, the kind of the old way of working was they would simply refer patients to us majority of the time. The patients would come with just the simple expectation of they're going to receive an injection because the musculoskeletal specialist said they needed one or they would benefit from one. So again, by working with the musculoskeletal triage service provider, what's happened now is they are introducing patients to pain self-management resources in that initial appointment. So in the clinic letter that the patient receives, the patient is signposted to some pain self-management material, either depending on the patient's access to the internet, it's either a pain rehabilitation or signposted website, or they can be provided with a paper-based resource there and then within the clinic. So again, between the MSK triage appointment and then them having a community pain service management appointment, there could be a couple of weeks, maybe 2 or 3 months in between, but the patient's got the resources to begin working on to become better informed. So when they arrive, we've found that the patients have a much better expectation, and they're more inclined to engage in the rehabilitation. Many often then change their mind and say, actually, the passive kind of approach with the medication or the injection isn't something we want anymore. They're more interested in the rehabilitation that we have to offer. So again, like the diagram shows, it was really about the drip feed effect. So kind of at the point of referral, if the GP, advanced nurse practitioner, the MSK service are able to begin the first drip feed, and then obviously we then continue that on, that helps to build up, I guess, in the patient system, more information, kind of knowledge, hopefully converts to better empowerment. The next avenue was to look at the local IAPT service, the increasing access to psychological therapy services. So they, again, were working initially were aware of our service, but not really fully aware of what we actually provided. Again, because of the historic nature of pain clinics being the place to send patients for interventions, medical management, i.e. medications and injections, there was a lack of awareness within the IAPT service that our community pain service actually offered and worked with patients using quite common psychological or psychosocial frameworks and approaches, such as the CBT, ACT, or CFT, cognitive functional therapy, compassion focused therapy approaches. So they were actually really surprised to hear that. I held an information kind of training session for all of the IAPT service, and then that was then reciprocated by the IAPT service holding an information session with our service, where we kind of explained to each of the services who we are, what we do, how we operate, the types of support we offer the patient. So that really helped each of the services to understand actually what we offer, how we operate, and it improved understanding between the services. And as a result of that, we have then developed a direct referral pathway. So if we assess a patient and it becomes really apparent that the patient has some significant emotional or psychological health need that is posing as a barrier to them engaging in pain self-management rehabilitation approaches, we can then, with patient consent, make a direct referral into the IAPT service for the patient to be picked up at the IAPT service, and the patient can be offered help and support, whether it's stress, a stress management course, or anxiety, low mood, low self-esteem. They can access their face-to-face, telephone or video, or even online support. So that's really helped to help the two organizations to work together to help support patients. And this has been really helpful over the last 2 years. But the limitation with IAPT is it only can work with a certain degree of complexity. So what we then did was approach the local secondary care mental health service, and we approached the local secondary care mental health trust, and again pretty much followed a similar approach to how we tackled with the IAPT service, in that we set up kind of meetings and information sessions between each service, where again I presented to the secondary care mental health team about how we work, who we are, what we do, the approaches we use, and again their service manager did something similar to our service. Because again, quite often on assessment within our service, it becomes really, really apparent that the patient's pain was often linked to some previous trauma or abuse, or even sometimes current abuse or trauma. And again, that was presenting as a barrier for the patient to engage because of the daily torment of the mental health burden they were under. And if it was so significant, IAPT are unable to support patients either because the patient may have some type of substance abuse or self-harm or severe depression based on the outcome measures. Again, both services were really kind of surprised, and in particular, the secondary care mental health service was really surprised to know that beyond the injections and medications, we were able to support patients on a one-to-one basis, in that we had an MDT team. It wasn't just a pain consultant and physiotherapist. It was actually involving CBT therapist, a psychologist, occupational therapy, and psychological well-being practitioners. So they were really kind of surprised that we had like a full MDT team, and we worked with patients depending on their kind of needs and requirements. And again, we developed a direct referral pathway. So if we received a referral from the primary care referral, whether that's the GP's practice or the advanced nurse practitioner or the FCP within the practice, again, because of the limitations of the wider health economy, a 10-minute appointment, often you don't have the time to scratch even scratch the surface sometimes of what's in the background to the patient's pain, if the ifs and whats and the kind of the complexity of what the patient's presenting with. So we would often then discover these kind of complexities, and we were able to now directly refer the patient straight into the secondary care mental health service for an assessment with the psychology team. If obviously it's something more severe, we're able to make a direct urgent referral where the patient can access kind of the crisis team, or they can have a visit from the community mental health team either that day or within the week or two. So that's really helped to streamline the patient's care and stop this fragmentation between this dichotomy of the pain is physical, the pain is psychological, the pain is both. So it's helped to kind of this kind of fragmentation, this kind of false divide between where services lie and what services can and can't do to help the patients. So again, we're trying to break down those barriers and help to get the patient the care they needed there and then, because quite often from listening to the patient stories, it was often a case of the patient was presenting in primary care 2-3 times or over 3 or 4 years. They were referred to physio with not much outcome, and they were being bounced back and forth because there was no real kind of full comprehensive understanding of the patient's needs and dilemmas. We then engaged with the local council run exercise referral scheme. So again, similar approach, kind of put on information sessions between each services so we could better understand what was on offer and what was being done. So where patients identified a goal around improving physical activity levels, we are now able to directly refer the patient into the local exercise referral scheme rather than sending the patient back to the GP for the practice nurse or healthcare support worker to refer the patient on. So we've now got direct access into that. But also, we have invited the local exercise referral scheme service manager to come and speak on our final session of the pain management program. So patients are able to understand that when they're leaving the pain management program, which is usually one of the main exit points from the service, that they've got another goal to work on for the following couple of months. And for patients that identify physical activity is one of their key goals and something that's really important to them and as part of their values they want to increase, then this was really a really helpful kind of stepping point for them to help continue on. And in the last week, we have just finished a trial of inviting the IAPT service to come and present on our final session of our 18-hour pain management program. So they have a 15-minute slot again, where they kind of just give a quick rundown to the patients on the pain management program as to what the IAPT service is about, what they offer, how they can help, and patients to those two services there and then can ask the service manager about being self-referred, and the clinician that presents on the slot is able to take a direct self-referral there and then within our service before they're discharged. So it just makes it so much more seamless and helps patients transition smoothly from our service on to kind of the next part of their journey. We're not we don't own the patient, we're not the be all and end all for the patient's journey. We can help the patient so far and help start the journey with the patient, and we can sow the seed for many aspects, but there are other aspects, for example, that are better fulfilled via the IAPT service, secondary care mental health service, the local exercise referral scheme. The next thing that we found was the local region in West Yorkshire that we operate in has a very high level of socioeconomic deprivation, finding a large proportion of our patients live alone or in isolation, with, again, often little interaction with their neighbours, their friends, their family. And a lot of patients in this group often want to remain under our service despite kind of reaching and completing the goals they were working on, or having met the goals and needs that they had and we had. So we established a direct referral pathway with the local social prescribing service. So the patient is linked directly to a social prescribing link worker, and the patients on the referral form, we can identify the needs the patient has or the goals the patient has, whether it's around social isolation, meeting new people, improving access to other aspects of their lives if they're having financial difficulty or housing needs, they're wanting to make new friends, or even kind of befriending schemes over the telephone. So that's really helped to support patients. And quite often, with a lot of these kind of additional services we've worked alongside, we're able to get the patient referred on, and within the time they're under our service, the patient's already receiving care from either the IAPT service or the social prescribing service or the exercise referral scheme. So while that is kind of getting up and going, we're able to kind of support the patient through whether kind of, let's say they're going to the exercise referral scheme and they're having some sessions in one of the local leisure centres or exercise classes, we can then help to kind of hone in with the goal setting or pacing. If it's a patient under the IAPT service, if it's appropriate, not in every case, but in some cases, we can work with the patient kind of concurrently. But in many cases, because of the large piece of work they need to do in IAPT, we will often discharge the patient at that time, and then the GP will re-refer them in 6 months or 9 months, whenever they finish that piece of work with the IAPT service, depending on the waiting time for the specific therapy they need under the IAPT service. So in terms of the local population needs, as I've mentioned, kind of within the West Yorkshire region of Huddersfield and North Kirklees, high levels of socioeconomic deprivation, but that is then compounded by a lower level of English proficiency. So in our service, if we have say a half-day clinic, often we will require the interpreting service for at least 1 in 4 patients, most often South Asian and Eastern European languages. And during COVID, that really pushed the technical advances in the terms of the way we were operating and supporting patients. So where patients have access to email and the patient is able to read or have a family member read to them via email, we're able to email patients language-specific resources in their first language. And where they don't have access to internet or email, we're able to get the admin team to post out a copy of the relevant pain management resources in the patient's first language. This has really helped to improve the effectiveness and being able to reach out to patients better than ever before. And again, because of the technical advances, YouTube and kind of audio visual material has been fantastic, because for many patients where English isn't their first language, but even their own first language, they're not fully proficient in terms of reading. They can understand and they can speak, but they might not be able to read. So for them, we've got access to some pain management material in video format, so the patient's able to hear and watch the material. So that kind of really helps the patient to engage. And obviously, everybody learns in a different way, whether it's kind of written, audio, or visual. So that's really helped to make the pain rehabilitation process a much richer and informative and interactive process than what it ever has been. And then in terms of pain management material in other languages, I have shared some resources here available in a number of other languages. The first link is there are pain management material in about 8 or 9 different languages. And then the second link, along with Pete Moore, that some of you may have heard of, the Pain Toolkit website. In my former service, we released the video in the Urdu language, so it's the Pain Toolkit video in Urdu. The Retrain Pain website, again, has a number of pain management information in around 15 to 20 different languages. And Pete Moore's Pain Toolkit website, when you go onto the website, in the top corner of the website, if you click on the Google Translate drop-down menu, there's a number of languages his website is now available in. And there's the Tame the Beast website. When it links you to the YouTube video, you can click on the closed captioning icon, and that will pull up the video and give you subtitles in 11 different languages. So that really helps to engage patients for whom English is not their first language, or for whom writing or reading is not very proficient. So they've got access to audio visual material as well. So I'm just going to, there we go. So that's me done. If you have any questions, feel free to ask, and I'll try my best to answer them.
That's brilliant. Thank you very much. Thank you very much, Shoaib. So I'm now going to introduce James Watson, who's our second speaker. James is a physiotherapy pain lead in integrated MSK and community pain management services in North Tees and Hartlepool NHS Foundation Trust. James, over to you.
Thanks very much, Sue. Thanks very much to ARMA for this opportunity to talk to you today about services to support people to live well with pain. And thanks everyone for giving up some of your lunchtime. So for those of you who don't know where Hartlepool or North Tees and Hartlepool is, we're up here in the northeast of England. And we've got a population of around 300,000 people. If Hartlepool and Stockton was a village of 100 people, then about 29 would be living in the most deprived quartile of England. 19 would have a long-term illness. 24 would be weekly binge drinkers. 20 would be smokers, and 14 would be obese. Now, both Hartlepool and Stockton have some of the highest percentage of the population with long-term MSK conditions, 25.6% and 23%, compared to the national average of 18.6%. And Hartlepool also has some of the highest levels of physical inactivity in the country at 28.5%, compared to the national average of 23%. So we can see that a large section of our population are living in deprived areas with long-term illnesses, including long-term MSK conditions, and of poor health-related behaviours, notably physical inactivity. So where were we on our journey to support people to live well with pain in 2019? Well, these images represent the picture in 2019. Siloed working, high opioid use, bottlenecks and rising waiting lists. As an individual in Hartlepool and Stockton in 2019, you'll have probably felt more like a basketball being passed back and forth from service to service, seeing the same service multiple times, and it was very common for an individual to be under multiple services at the same time for the same condition. Now, this is clearly not an efficient or effective use of the system and not in alignment with the right care, right place, right time agenda. Hartlepool and Stockton had also been a significant national outlier in relation to the number of opiates prescribed in relation to the local population, being in the 96th to 99th percentile of CCGs nationally the preceding 5 years, and this equated to an annual spend of approximately £750,000. So with high opioid rates, siloed working contributing to several bottlenecks in the system, contributing to rapidly rising waiting lists, we knew we needed to change. Building on the work undertaken in collaboration with our CCG in 2016 and 17 to mandate the use of the MSK service as a single point of access for all orthopaedic conditions from primary care, the intention was to improve the pathway for patients experiencing persistent pain by working more collaboratively, integrating our MSK service and pain management service within our trust, creating a single point of access for individuals with persistent MSK-related pain. A working group was formed with stakeholders from across the system, and we also sought feedback on our proposals from those with lived experience. Having reflected on this process, we felt we should have more actively involved those with lived experience within the process, and we are taking steps as an integrated service to ensure that any future changes are truly co-produced. Drawing on audit data from the Royal Berkshire NHS Foundation Trust, who set up a similar service model, we estimated that approximately 50% of referrals coming into secondary care pain management, here in yellow, were actually MSK related pain that could be managed without any input from secondary care. Now, if these patients could be managed without input from secondary care pain management, we could improve access to secondary care pain management for those with non-MSK related pain, and also free up some capacity within secondary care, which could be used to support the pathway in the long term, and also support with opioid gabapentinoid reduction clinics. A key part of the service was to see the pain psychology service, here in red, reformed to create community pain management, or CPM for short, which would break down historic siloed working and be a collaboration between all three care groups within our trust, embodying our trust values and strategy. Critically, CPM would need enhanced psychology and pain physiotherapy resource. The rising waiting list stem from a historic lack of funding, for assessments and pain management programs, and thus increasing the therapy resource was deemed essential to ensure the success of the pathway. We also aim to refresh our pain management programs to Living Well with Pain programs in line with leading services nationally to shift the emphasis from pain towards living well. Also, with our population having a high prevalence of long-term illnesses, including long-term MSK conditions, and the links between these components and physical inactivity, which we knew was prevalent within our population, we aim to embed physical activity within the CPM pathway by increasing the physical activity component of our Living Well with Pain programs from one session in our old model to every session, enabled through enhanced physiotherapy resource. So this clinical pathway serves as just one of many spokes within the integrated MSK service as part of our active hospital pilot, of which our trust is one of 4 pilot sites nationally, aiming to embed physical activity within clinical pathways. This fits with the NHS long-term plan and our trust vision by using physical activity to support the population health agenda. In addition to increasing the resource and quality of care delivered to those who reach community pain management, we also felt we needed to look further upstream, with the view that if we could improve the effectiveness of pain management interventions at an earlier stage of the individual's journey, the demand for community pain management and secondary care pain management would reduce. We've decided to implement a stepped model of care where most individuals who present with MSK related pain would be triaged initially to the core MSK physiotherapy service here in Orange to receive first line pain management interventions. And these would include using a health coaching approach to help the person make sense of their condition, functional rehab guided by their valued activities, sleep hygiene, relaxation, general activity guided by valued activities, activity pacing, providing online resources, plus or minus a discussion with a prescriber for appropriate analgesia, and even plus or minus acupuncture or manual therapy. Now, enabling the core physiotherapy team to deliver this standard of pain management intervention, we knew would require lots of training. To facilitate the transference of skills across the integrated system, we plan to draw upon existing core MSK physiotherapy staff to work in CPM 1 day a week rather than just employing 1 or 2 full-time members of staff from a physio perspective. We felt that this would create workforce resilience across the system, and also by providing an opportunity for more clinicians across the system to develop pain management skills. This would create a developmental pool for clinicians within the MSK service, ultimately increasing workforce retention. The integration would also allow for an MDT to be formed to allow clinicians from across the system to discuss complex cases and agree the next steps in management. So the new model sounds great: enhanced biopsychosocial care, MDT working, potentially reduce weights, but all this comes with a cost. How do we fund such a project? Well, given that our opioid prescribing rates were a significant national outlier in the context of a national drive to reduce the number of opiates prescribed, we put forward an invest to save business case. If we could provide enhanced psychological and pain physiotherapy interventions in addition to opioid reduction clinics, then there may be a reduction in opioid prescriptions, with these savings being used to sustain the pathway in the long term. So we were able to secure funding from the North of England Commissioning Support, who recoup unspent money regionally, which can then be bid for. Finally, we could cross the start line. Now, this was in late February 2020, and the events that unfolded in March 2020 delayed our start for a few months until May 2020. Now, setting up a new pathway with a new integrated service is a challenge at the best of times, but in the backdrop of a pandemic has made for tough going. So where are we now? So this is a bird's eye view of our integrated service, which unfortunately I don't have time to go through in detail today. But the largest patient flow is through our red route, where individuals receive a triage assessment by a member of our psychology team, and in partnership with that person, triage them to the most likely helpful support. Most people go on through to our Live Well group taster session, which is a 90-minute session for individuals to explore if they would like to go on to attend one of our full programs. The taster session is a new addition and has improved our resource utilisation, as historic high DNA rates on that initial appointment meant that those places were lost for the full 6 or 9 weeks that those programs last. Following the introduction of the taster session, our DNA rate on initial appointments has dropped 20% to just 7%. And we also have anecdotal evidence from clinicians that attendees are more activated to make changes, which suggests we're more effectively getting the right person to the right intervention at the right time. Now, embedding physical activity within our programs is also going successfully, with many attendees reporting that the physical activity component is actually their favourite part of the program. And we know if they maintain their engagement with physical activity, all the evidence suggests that they will be both physically and mentally healthier and less reliant on hospital services in future. So what about our clinical outcomes? Well, we primarily looked at pain acceptance and well-being, which are key predictors of whether someone is living well with their pain. And we can see, so our pain acceptance is on the left, well-being obviously on the right, and the blue chart is pre and the orange is post. And we can see that for both our 6 and our 9-week programs for pain acceptance and for well-being, people who finish our programs, their pain acceptance and well-being increases. It is worth noting though that these are just pre and post measures, and we don't know what's happening in the long term. We don't know if they get better, we don't know if they get worse, or if just the effects are maintained. And we are looking to plan to automate the collection of our outcome measures to automatically collect long-term follow-up data to see what happens with people once they leave us. On to our waiting lists. Well, it took us a couple of months from our service launch in May to get a more accurate handle on the data. But as you can see, in July 20, our waiting lists were not in a very good position, with some people waiting a very, very long time. Now, over the first 6 months, we were able to reduce the number of people waiting for that initial triage assessment by over 4 times, with the average wait dropping from 40 weeks to just 3 weeks. The waiting list size for our taster sessions almost halved, and the average wait time reducing from 58 weeks to just 7 weeks. In July, no one had attended our taster sessions, so we didn't have any data to make the comparison, but overall some excellent improvements in that first 6 months. As we've moved forward another 6 months from a year on from our first evaluation, whilst our waiting list is still in a much better position than they were a year ago, they're now starting to head in the wrong direction. So what are our reasons for this? Well, there are several reasons, and potentially the biggest is that we're a victim of our own success. The feedback that referring clinicians are getting from patients is very positive, and we've noticed a 53% increase in referrals compared to our previous year. The second most likely reason is staffing. So this is a combination of redeployment, but also psychology workforce, where we've had a number of our team go off on maternity leave, and we haven't been able to backfill that very well. And there's also been some additional capacity which is being used for staff training. Other pressures include 50% reduction in our group capacity based on pre-COVID levels, and also admin pressures and annual leave. People have taken more of their annual leave in the second half of the year when you can actually do something, which is no surprise, I guess. But what about opioid prescriptions? So this gets slightly complicated. As of April 20, the CCGs in Tees Valley merged. So Hartlepool and Stockton merged into Tees Valley CCG, and therefore the data that I have access to on open prescribing has also been merged. But as you can see, the picture is similar from Hartlepool and Stockton to Tees Valley, both in the 99th percentile back in 2019. Now we can see that the number of people taking opioids and the CCG's relative position in relation to other CCGs has been improving year on year. The story is also similar for those on high dose opiates, with the number of people on high dose opiates and the CCG's relative position improving year on year. Now, it is important to highlight that our pathway is just one of several factors which have contributed to this reduction in opiate prescriptions across the CCG, with lots of work happening in several areas of the system. So a year on from the service launch, our waiting lists are in a better position. People who attend our programs have improved well-being and pain acceptance, and less people are taking opiates. But it's not just about the numbers. So I'll let you read this feedback from a healthcare professional who's now working in CPM, who was also working in the old model. And here's some feedback from a Live Well with Pain program attendee. And I think it's the end bit here which really stands out to me. It hasn't cured me, but it's given me something to work with and made me feel a bit more positive. And really that's what a Living Well with Pain program, I think, aims to do. But it hasn't all been sunshine and roses. Whilst thankfully things have never got this out of hand, as you would expect when bringing together several teams previously working in silos, there have had to been a lot of very challenging conversations, and these continue today. The good news is as we have become more integrated and our relationships have strengthened, the conversations have gotten easier. Now, as I mentioned earlier, COVID has brought with it a number of challenges. So we tried to run our groups virtually. However, the lack of digital literacy and preference within our population meant they were not viable to run with any level of efficiency, and therefore, in line with government guidance and under the support of our infection prevention control team, we've conducted face-to-face groups throughout the pandemic. The 2-metre rule has meant a reduction in group capacity, as I said, greater than 50%, and we've also had our community venues closed during each full lockdown, which meant we've had to cancel groups and have had difficulty finding estates outside of the hospital and inside the hospital. Redeployment, this has probably been a massive one, a massive impact on us. Redeployment, social distancing, they've both meant that it's been very difficult for us to come together as a team and regularly integrate, and we went through a 6-month period where we had no team meeting, which massively impaired our ability to build relationships and work collaboratively. And I think ultimately has exacerbated the natural friction which comes from bringing together multiple teams. So how are we keeping on going? How are we funding this new pathway? Well, we've decided to continue to fund the integrated pathway via our integrated MSK service, drawing on some of the funds secured from the MSK service being awarded the FCP contract. And I think this is one of the benefits of having a truly integrated service, as it allows you to be slightly more flexible in how you utilize the resource within the system. So what's my biggest lesson learned over this past year? Well, this is the Infinity Bridge in Stockton-on-Tees, and my learning is that you cannot build a service to support people to live well with pain alone. You need to build many bridges across many areas of the system, and this is a theme which actually came out in Schwab's talk, I think. So how do you build strong bridges? Well, yes, you can build bridges by doing away days, and we've been fortunate enough to get out and have a meal in Copper Kettle, which is a nice restaurant, and have even had a garden party when you could do so with COVID. But what's the best way to build bridges? Well, I put it to you that you have to start from the tea room. The team has to be integrated, working in the same space, the same physical location, sharing the same kitchen and meeting area, as it's these informal passings where the relationships are built, skills exchanged, questions answered, and people grow. Now, being a service with input from all 3 different care groups within the trust, historically working in very different locations, it's meant we don't actually have a tea room. We've mitigated this a little bit by running clinics side by side, and where possible, in the brief gaps between clinics, we're able to have those brief moments where that magic really happens, where problems are highlighted and resolved, ideas are sparked, and most importantly, those relationships are built. So I put it to you, it's the physical location or homes of services that affect the level of integration and collaboration that is achievable within and between services. And this ultimately extends across the wider health and social care system. With care increasingly being moved out into the community, how can we ensure that these new homes of our services are able to bring together different professions and services who work in similar areas of the wider system? Perhaps there is a digital solution. However, we're well over a year into this forced digital transition, and I'm yet to find something as effective as a tea room for sparking collaboration. So by starting from the tea room, integrating the team through shared spaces, we may build the relationships and skills which will ultimately allow our systems and those who work there to thrive. So where are we going? I'll finish with kind of 3 key points here, which include a coaching culture, a public health campaign, and becoming more data-driven. So we're in the process of embedding a health coaching approach across the integrated MSK service. The ICS recently funded a 2-day course, which many of our team have been on health coaching and motivational interviewing. And we're providing additional support to clinicians with further training and supervision so that they're actually able to embed these skills into practice. In line with the Better Health agenda, we have a project group with the CCG looking to run a public health campaign to raise awareness of the risk of high-dose opiates locally, and where individuals can access that support to reduce their prescriptions if they so wish. And finally, we're improving our ability to be data-driven through automating the collection of our patient-reported outcome measures and patient experience measures to ensure that we can audit the quality of care that we deliver to ensure excellence is our standard. We're also redesigning our clinical systems so that we can more effectively and efficiently track the demand within our services and redistribute resources to where they're most needed. Thanks again to ARMA for this opportunity to talk to you today about services to support people to live well with pain, and thanks everyone for listening. I welcome any questions that you have. I'll stop sharing there.
Thank you very much, James, and also thank you very much to Shoaib for your presentation earlier. We've just got a tiny bit of time left for Q&A. So if anybody does have any questions, please do pop them in the chat. One question I had for Shoaib, and then maybe James can comment. You talked about this thing about the pain is physical, the pain is psychological. Well, no, it's actually both. That's a very hard message or hard conversation to have with a patient sometimes, where the psychological aspect is seen as not believing it or thinking it's all in your head. How do you go about having that sort of conversation with people? What are the key things?
Yeah, absolutely. So I think the key thing is about validation that yes, your pain is a physical experience. You know, you have pain, you feel it in the knee, it exists, it's real. We believe you. But then it's about linking it into, so when you have the pain, how does that make you feel? How does it make you behave? And linking in with the kind of experiences that the patient attaches to, well, when I have that flare-up of pain, I can't do this, or I do this, or this happens. And that then kind of links in with the other kind of aspects that are really important.
Okay, yeah, that's really interesting. James, have you got anything you wanted to add to that?
Yeah, I think from my perspective, it would be curious and ask lots of questions before diving into telling too much, which depends which area of the system you work in and the constraints that you have. I think I'm very fortunate in getting an hour with someone, so it allows me to spend that time and not tell too early, and build that therapeutic relationship, ask the questions which get that individual to identify that actually there are these multi-dimensional biopsychosocial factors which are contributing to my pain. So they're kind of those light bulbs are happening before I would then go in and start to tell and explain. And I can see Chris is on the webinar, and so it's very much the stuff that he's one of the experts in is that cognitive functional therapy approach. That's how I go about it. So in short, it's probably less telling, less explaining initially. Build that therapeutic alliance, build that trust, and raise awareness of that person to their context, and then you can start to help them understand it, perhaps through explanations and analogies.
Right, that's really interesting, because that is something that comes up a lot, as you can imagine, when we're talking about supporting people with pain. And then both of you have talked about communication, integration, services working together, people working together. Have you got any tips, James, on how to approach a service that you want to engage with that you're not currently engaging with?
Well, I would say the first thing is try and get a meeting with them. And in my experience, it really is, it's getting in the room, which I know has been quite difficult these days. It's getting the room, and probably similar to my last answer, is get in the room and listen. What do you need? How can we help you? What's your experience? And just sharing perspectives. And I think depending on what service it is, and in our, as I alluded to in my presentation, I've had to have a number of initially quite fiery conversations with different services, probably because part of them are coming from a place of threat in certain ways, but it's really listening, and once you start having that conversation, you tend to realize that we're all here for the patients. We're all here to try and help our community more, and aligning on that shared sort of purpose and vision. The kind of conflict and threat kind of fades away. I've probably rambled on enough there.
That's great, thanks, Sherry. But you've obviously done a lot of this, engaging with other services. What would your top tips be? I'm not going to ask you which ones were most difficult, because that will get you into trouble. But
yeah, I guess yes, similar to James, kind of the difficulty was trying to pin down who is the actual kind of clinical manager, and often the admin team providing you with the direct contact details for the clinical services manager, so you could establish those early communication and two-way conversation, which for me was most part via emails to get some kind of dialogue going. Then we had some telephone and face-to-face, and then we got these kind of between service meetings going. And yeah, I think it was all about putting the patient in the center and saying, right, this is the patient, this is the needs they have, and then thinking, right, well, how can we design the local services to meet the patient's need in the middle, rather than it kind of being a very kind of linear and back and forth and kind of quite a messy web, and just trying to make things a little bit more succinct.
That's great, thank you very much. And we have unfortunately run out of time, and I can see that people are starting to have to go away. So I'd like to thank you all for joining the webinar, and particularly to our two speakers for such interesting presentations and question answers. So I hope everybody found it useful, and the recording will be available online, and you should get a link to it. Please do share it with anyone that you wish to share it with.